Okay, great. So again, welcome to our first Echo in March. Please, we'll just go through some housekeeping and reminders and intros, and please enter in the chat if it's the first time that you're with us, your name, where you're from. If there's more than one person with you, enter that person's name as well. We're very, very fortunate to have Dr. Ariana Tart-Zelvin, neuropsychologist at the Center for Healthy Aging, with us today, and she's going to talk about neurological assessment and diagnosis of dementia. And then we have a terrific case presentation with Dr. Sylvia Russo, member of our community, and discussion. Excuse me. So as I said, please do rename yourself first and last in clinic. And if you're not talking, then mute yourself if you can. And we get it if you can't turn your video on, but we do really like to connect with one another and support each other through the thinking about the case or asking questions. So if you can, do share your camera, turn it on, or turn on your video. And if there's other folks, let us know, as I said. Okay, so we have CME for all Washington, University of Washington faculty, staff, and students. If you haven't already, please do register by sending your email address, your UW email address, to this phone number, and then you can text 8574 after you receive a email from that number. For all other attendees, please let Sammy know, and she can track your attendance and CME. There's a number of echoes through the University of Washington. I'm not going to read them all. Many of you have seen these. They're outstanding. Try to come if you can. There's one on TBI, psychiatry and addiction, telehealth. Also a hotline for people who have high-dose opioids and complex pain regimens. This one, 844-520 pain consultation number, and then a tele pain series that is also CME accredited. Additionally, there's terrific UW psychiatry grand rounds with a lot of overlapping topics of interest, behavioral challenge, psychosis, burnout. So there's a great archive that you can watch, and then for viewing later or available via Zoom, as you see here. A reminder regarding HIPAA and PHI. So these sessions are recorded. We keep everything confidential. We don't want to ever display any information that could reveal any identity of patient or family members. Okay, and then please complete the 1-minute post-session survey. We do value the input, and we try to take it to continue to improve these sessions. Okay, so coming up, Trang Lee, one of our hub members, fabulous hub member, Dr. Trang Lee, is going to talk next about pharmacological treatments of dementia and management of neuropsychiatric symptoms. Then Mary Grace. We have a lot of great topics in the ensuing sessions, and please we invite you to bring your cases forward. As we've said on a number of occasions, there's no case that is too complex or too simple, or too advanced or too upstream early. We can always learn together. So bring your cases, reach out to Sammy, email her, put it in the chat, however you want to connect to bring these cases forward so we can continue to learn together. We have CME, as I said, through the University of Washington. We have no financial relationships to disclose. Here's our hub team smiling at you, and representing a number of health systems. And here you are, this wonderful community. We've provided 1,500 instructional hours since the beginning in June of 2020. Over 70% of survey respondents said that they would implement a practice change based on the information that they took away from these sessions, and lots of different sites. We do want to continue to grow, so spread the word if you'd like, and if you think that you know somebody who would be interested or who might benefit from participating in these sessions. Okay, so now I'm super grateful to welcome and introduce Dr. Ariana Tart-Zelvin. Some of you may know her. She is the neuropsychologist at the Center for Healthy Aging, and she agreed with very short notice to come and give this talk. So we're even more appreciative of her time. And thanks so much, Ari. She's going to talk to us about neurological assessment of and diagnosis of dementia. And I will stop my share. Thank you again.
All right, thank you so much for the introduction. Let me just share my screen here. Okay. All right, so I will be talking about neuropsychological assessment and the diagnosis of dementia. I have no disclosures to announce, and these are the, kind of main objectives for the talk. To go over some of these may be more familiar to some than others, but hopefully something on here will be helpful for everybody. And just as a quick review, what is neuropsychology? So neuropsychology is an applied science concerned with the behavioral expression of brain dysfunction. So we use paper and pencil tests and computer tests to evaluate or assess individuals. And our evaluations can be very helpful with diagnosis at times, treatment planning, contributing to multidisciplinary care centers, rehab, also research or forensic evaluations. And with our evaluations, we try to assess several cognitive domains. This is, a list primarily of what we look at. Each of these domains is ideally assessed to some degree. We can assess them to varying degrees. Usually depends on the referral question and also the age of the patient. I did just want to highlight at the bottom something that people are not always aware of is something that we assess is effort. So sometimes patients might have some type of secondary gain. So for example, they stand to, make money in a lawsuit, or they're trying to get more services, get a higher level of connection with their hospital, if they actually show cognitive impairment. And so sometimes people have some incentive to try to perform poorly on our tests. And so it can be really helpful to know that we actually have measures of effort both embedded into some of our tests, but also standalones. This can be really helpful sometimes if you have a patient with a lot of medically unexplained symptoms, or if you've tried everything and they're just not responding. Sometimes it can be helpful to refer for a neuropsychological evaluation just to see, hey, were there any issues of effort? And typically it's, viewed if somebody performs well on these measures of effort, so they really gave good effort, and they demonstrate difficulties on cognitive measures, then it's a true cognitive impairment. If they do poorly on the measures of effort, we can kind of take a step back and question maybe the bigger picture of, what's going on here. So I just wanted to highlight that not as many people are aware of that. These are some common questions that can typically be answered by a neuropsychological evaluation. So just, what is a patient's baseline functioning? Is their cognitive pattern consistent with a particular neurodegenerative condition? How do these results relate to a patient's functioning? So we can give, measures of judgment and speak to, should this person be making medical, legal, financial decisions on their own, things like that. These are questions that either we usually cannot answer or would be hard to answer. So we are PhDs, we don't, prescribe medications. We don't have a magic 8-ball. We can't predict the future. We can try with serial assessments to look at, decline or, improvement over time, but it's difficult to do that with a high degree of accuracy. Some neuropsychologists provide follow-ups with cognitive rehabilitation appointments. Most, I would say, don't. So usually patients only see us for their evaluation and their feedback. And so that's where it's really helpful to have other providers as part of the patient's team. And what I'll be focusing on today is the diagnosis of dementia. So I know everybody's seen this graph a million times, so bear with me. But just a quick reminder that dementia is an umbrella term that refers to both a decline in cognitive abilities that's measured objectively and a decline in a level of functioning. So that could be instrumental activities like the ones I've listed here, or sometimes patients can be so far progressed that they're actually showing a decline in just basic activities of daily living, such as, feeding themselves, bathing themselves, dressing themselves. But when they meet criteria for both, then they can receive a diagnosis of dementia or major neurocognitive disorder. And these are this is not an exhaustive list, but these are the most common causes of dementia. So Alzheimer's disease tends to account for 50 to 70% of dementia cases, vascular disease about 20 to 30%, Lewy body about 10 to 20, FTD about 10 to 15. You can also break some of these down. So for example, frontotemporal dementia, there's different kinds, but they are less, or FTD in general is less common than most of the others. And in an ideal world, we would catch cognitive changes as early as possible. So there's very clear benefits of early detection, helping the patient with earlier interventions, improving their quality of life, hoping to maintain independence. It's a lower cost on the healthcare system in the long term. And we can detect, earlier things using other, parts of our care team. So primary care providers might observe something first, as our frontline providers. It could be a patient's, family member that says something, their boss that says something. It can kind of come from all different directions. And one, tool at our disposal are cognitive screeners. So there's a lot of them. I'm just going to go over a few of the main ones. So the MoCA, for example, the Montreal Cognitive Assessment, is considered brief to a neuropsychologist since we meet with patients for hours and hours and hours. So, 10 minutes to us isn't a big deal. So we would consider it brief. It is accessible in a lot of languages, and it assesses several distinct cognitive skills. It's reliable. There's formal training, which is really nice. There's a tablet available. There's a low education version available. So there's a lot of positives to it. There's also the SLUMS, the St. Louis University Mental Status Exam. Similar, it comes in a lot of languages. It's well validated. It also assesses several different distinct cognitive skills. The SLUMS and the MoCA compared to the very commonly used MMSE, the Mini Mental Status Exam. The MoCA and the SLUMS appear to be better at times, so it's a little more challenging. There's a broader range of cognitive domains assessed. There's better sensitivity, and there's an education correction, which can be really nice. That said, all of these have limitations to them. They don't usually work well with highly educated individuals. Those patients have a lot of cognitive reserve to pull on, and so these measures aren't challenging enough for them. Specifically with, concerns for dementia, there's not a lot of memory testing involved. They don't really get after more complex skills. So there's a lot of ways in which these measures could be improved by including other components, being a bit more thorough. But even as is, if I were to ask, for example, a primary care provider to add a 5-minute screening measure to their appointment, that could be 25 to 30% of their time with that patient. So while it would be amazing in an ideal world if I could wave my magical wand that every primary care provider would be able to include a cognitive screener in their evaluation, I also understand that that would be very challenging to do. So what I also wanted to provide in this presentation was, let's say the patient's already been diagnosed with dementia. when you have your appointment with the patient, no matter what type of provider you are, what are some things that you could hone in and focus on including in your appointment with the patient? So these are some general recommendations. Doesn't really matter what kind of dementia the patient is diagnosed with. All of these are a good thing to consider. So aspects of lifestyle medicine, addressing sleep problems, diet, exercise, are they living a sedentary lifestyle? Making sure they just have all their affairs in order, medical, legal, financial planning, having, the difficult conversations. Sometimes they need the white coat, to encourage talking about future plans. What do they want to do with their money? How do they want to be taken care of? Are they in their forever home? Making sure that these things are happening. And also, encouraging healthy things like volunteering, pet ownership, having the bucket list conversation, right? You may have less time than you originally expected. So, what are the things that you really want to do in life? And ideally, again, if I could wave my magic wand, we would all have ample time to assess all of our patients and to talk about every one of these things with all of our patients. But again, that's not really the reality that we live in. So, what I want to suggest are the important factors for the different causes of dementia. So, what would be the top three most important things to focus on if a patient is diagnosed with Alzheimer's disease as opposed to FTD? And for a few minutes, we'll pretend that it's as clean as that and that patients are diagnosed with one thing, even though many of us know that a mixed pathology is actually a lot more common. So this is a little bit of, a simplified version. But let's say you have a patient come in diagnosed with Alzheimer's disease. One of our biggest goals is to slow the decline as much as possible. We know that there are no cures right now that exist for any neurodegenerative process. And we also know that we can slow the rate of decline with different medications and lifestyle behaviors. So with these patients in particular, it's really important to focus on exercise. And newer research has shown that both aerobic and resistance training, whether that's body weight or bands or weights, is incredibly helpful. Even 2 weeks of consistent exercise has been shown to improve both hippocampal volume sizes, but also memory on objective tests. Their diet is really important to focus on. So suggesting, anti-inflammatory diets, Mediterranean diet or the MIND diet, keeping them active and engaged. I think we've all seen, the patients that come in and they get this diagnosis and then they just spend the next year sitting on their couch watching TV, not really engaging in life, and they have the fastest decline. And also one of those, difficult conversations. Hey, it's an important time to make memories while you're still the person or as much of the person as you are today. With vascular disease, if somebody comes in with a truly, vascular profile, I almost get pretty excited because I know there's a lot of things that we can do to combat the changes that they're likely experiencing. So we really want to monitor associated vascular risk factors. So hypertension, hyperlipidemia, diet, exercise, things like that. And I want to just briefly, I'm not going to go into an in-depth case presentation, but I wanted to just show you 2 examples of patients that I've had who came in with somewhat of a vascular presentation. So the first patient was an 85-year-old right-handed individual with 20 years of education, presented with concerns about his memory. He had atrial fibrillation, coronary artery disease, hypertension, hyperlipidemia. His imaging revealed mild atrophy and mild scattered white matter disease. And very, very intelligent individual, a lot of cognitive reserve, came in with just a couple mild weaknesses. And then he spent the next 2 years completely changing his diet, exercising, taking his medications as prescribed for his hypertension and his hyperlipidemia, and really making major lifestyle changes. And as you can see here, from the 2022 to the 2024 scores, there are several different cognitive domains in which he improved. One of the most telling ones you can see under attention and executive functioning under trail making test, he went from the 19th percentile on our Trails B test to the 82nd percentile. It was pretty remarkable. So in 2022, I diagnosed him with mild neurocognitive disorder. In 2024, I took that diagnosis off his chart, which was pretty exciting. Quickly or briefly, a second patient, 66-year-old right-handed man with 18 years of education, also presented with memory problems. In his chart, he also had AFib, sleep apnea, CAD, hypertension, hyperlipidemia. Imaging was recommended, but he hadn't completed it yet. And I saw him in 2023 and 2024. So I just want to show you, pointing out some of the scores in 2023. He had, low working memory. He definitely had, learning and memory difficulties, difficulty with attention and executive functioning measures. Similarly, for 1 year, he did every recommendation. He used my report like a checklist, and he went one by one, really changing his diet, increasing his engagement, signed up for classes, got on certain medications to address his vascular risk factors, and made a lot of positive lifestyle changes. So the first time when I saw him, I diagnosed him with multi-domain mild neurocognitive disorder because of all the different domains he was showing weaknesses in. When he came back, he only had memory problems, which is, still a problem, but he had shown improvement in all these other areas. And now he's engaging in cognitive rehabilitation to really focus specifically on just the memory problems, rather than trying to focus on strategies for memory, attention, executive functioning, processing speed, which would be a lot for a cog rehab person to try to focus on. So this is just a patient, again, making lifestyle changes, regularly taking medications that were already prescribed to him. And there was this much improvement in 1 year. So it was honestly, it was very exciting. And the patient, took the feedback really well. Now, Lewy body, this is usually, you see an onset of 50 to 70. So just as a reminder, hallmarks of Lewy body: cognitive fluctuations, difficulty with executive functioning, visuospatial difficulties, dream enactment, so REM behavior, sleep disorder, and then, a big telltale, well-formed visual hallucinations. Oftentimes, the visual hallucinations are animals or people or children. They're not typically threatening or scary to the patient. They can definitely be scary to family, though. So one of the things that should be emphasized if you're following up or seeing a patient with Lewy body disease or Lewy body dementia is medication management, so for the symptoms that they're reporting, but psychoeducation. This is a big deal. And I didn't emphasize this as much with AD because there's a lot more out there with AD, and it's typically associated with people's, declining memory. It's not quite as shocking. But if all of a sudden your spouse is sitting next to you and seeing, your dead cat in the room and their old buddies from the war who have passed away, that might be pretty scary for the family members. So, and the patient potentially. So it's important to take a minute and focus on psychoeducation. Also, driving ability. So again, a reminder, right? You have those executive functioning weaknesses, sometimes visuospatial weaknesses. So driving can actually be, an important area to focus on. And then depending on their age, should they really be working with a geriatric primary care provider and psychiatrist, or can they continue with their own, again, taking a look at their age? Now, let's say you have a patient with Parkinson's disease dementia. So one of the big, things to focus on here is their executive functioning weaknesses. So again, driving, but all those complex tasks, cooking, managing medications, finances, it's going to be really important that they and their family focus on ways in which they could address these potential weaknesses or weaknesses that might occur over time. Also, about 80% of Parkinson's patients end up reporting or endorsing a significant number of mood symptoms, whether it be anxiety and or depression. And so if you're a provider that follows up with the patient on a regular basis, it would be really helpful to incorporate maybe just a quick mood screener or a quick conversation with the patient so that you can try to stay on top of that. And lastly, exercise. So research shows that physical therapy and exercise can help Parkinson's disease patients in particular quite significantly. So Huntington's, this is another common cause of dementia. It is genetic. So with this particular case, I would encourage genetic testing for the family members if they want to know. I think that's an important conversation to have. Not everybody wants that information. They may just want to live their life on whatever trajectory they're on, and they don't want, that type of health information to change it. Or maybe it will be valuable information that might change how they live their life. Either way, it's an important discussion to have. Research also shows that stress reduction, especially early in life, as well as diet and exercise, can be pretty influential in the progression of the disease. Social engagement is important. And then again, having one of those difficult conversations. Hey, you may not live as long as you thought you were going to. Have you sat down and written a bucket list? What are things that you really want to do in life with you or your family? And encourage patients to actually have that conversation or engage in that exercise. Another common cause is substance use. So, an obvious recommendation, reduce or eliminate substances, but also involvement in support programs and therapy is likely very helpful. And the reason why I emphasize this specifically with substance use cases as opposed to the other ones is because substance use dementia cases are often viewed a little differently, mainly by family and support members, because there's a component of choice. Because this person chose to use and potentially abuse these substances. People don't get Alzheimer's disease by choice. People don't get Huntington's by choice or frontotemporal dementia by choice. So these patients and their families might present a little differently, and it's important to acknowledge that and to try to help them find resources that might be helpful in addressing those complex emotions everybody might be feeling, maybe to repair some damaged relationships. And there's also a really, big push to focus on diet. So if patients can reduce or eliminate substances and improve their diet, so they have good nutrition and their brain is getting all the nutrients that they need, they can actually reverse some of the cognitive weaknesses that we see on testing within 30 days even. The worst are the patients who are replacing their meals with a substance, for example. So let's take alcohol, for example. If they are heavily drinking and not eating well-balanced meals, they have the worst outcomes. So consider referring patients to a nutritionist to really try to educate and follow up on their diet. That's something that's very helpful with these individuals. And then lastly, for another common cause is frontotemporal dementia, or FTD. Personally, this is my least favorite diagnosis to give to a patient. I think it's one of the most cruel disorders that we have, mostly for the family members. It is very fast. It progresses very quickly, and it oftentimes dramatically changes a patient or a person. It can change their behaviors quite significantly. It can affect their ability to communicate. So it's not always their memory or their behavior. For example, there's a variant PPA, primary progressive aphasia, that really attacks a person's language abilities. And so they can't communicate or say what they want to say. Other times it could maybe be the behavioral variant and they start acting like a 7-year-old. The changes happen quickly. People don't often have a lot of time left with the person. So it's very difficult for family members to adjust very quickly and potentially lose someone that they love very quickly. So medication management for these symptoms, finances is a big deal. So they likely will have compromised judgment if they don't already. I had an FTD patient once who wanted to leave all of his money to his favorite tree in the park. And they had nothing in place, absolutely nothing. And as far as financial paperwork, a will, a durable power of attorney. And so the family had to really get on things very quickly. Educating the family, explaining to them that their behavior is not within their control, what they're saying is not within their control, that it's the disease, behaving, or the disease talking can be helpful for them to know. I often help patients write a little index card that they can carry around with just a 1 or 2 sentence brief explanation in case they needed to show it to someone in their everyday interactions, in case they say the wrong thing to the wrong person. And then a big one is obviously driving. So it's, maybe it's time for a formal driving evaluation, because compromised judgment, impulsivity, right? Those, frontal lobe weaknesses can be a very dangerous combination when we think of driving in particularly. So that's another, important area to focus on. So I want to just give a special thanks to obviously my patients and their families, all of our staff here at Swedish. They all support me tremendously. Dr. Nancy Eisenberg, Samantha for organizing and planning and getting all the things and making sure I do all the things. This is just our Center for Healthy Aging at Swedish, which I think most of you know about. And I just want to thank everybody for giving me the opportunity to give this talk.
Thanks so much, Ari. And we have time for some questions or comments. And this is an opportunity for you, if you've referred somebody for neuropsychological assessment, or if you're wondering about who you'd want to refer, to ask those questions or share any experiences that you've had.
Yes,
Yeah, Jeff.
Oh,
Firstly, outstanding talk, and I really appreciate it. I have a recent case, if I can just very briefly present it. A gentleman in his 50s with chronic pain who's on 60 MEDs from a pain clinic, obese, who works in an extremely highly sensitive area running a team. And I pulled him from work when he came in to see me, saying, because he said he couldn't think as clearly, had been feeling this, his memory function wasn't as good, and just got neurocognitive testing, which in my community in Yakima was almost impossible. So he had this actually eventually engage somebody from your office who linked me with an attorney who's now connected him for testing. And he ends up scoring low on a number of functions, including speed of processing, memory, slow speech, and a couple other things. And the person who did the neurocognitive testing commented that possibly some of this relates to the use of opioids and some of this to his having chronic pain. And I'm wondering if and he's doing all the lifestyle stuff. He's lost a lot of weight. He'll probably end up with bariatric surgery, anything to try to help him with his pain, to get him off the pain medicines, see what helps. But maybe you could comment, since we have so many pain patients in this country, how much of that plays a role, and how can we help these folks in these situations? Thank you.
Yeah, so just to weigh in, and I'm going to say professionally and personally, last year I had hip surgery, and I was walking around for about 7 months in a lot of pain, and it gave me a new perspective on chronic pain patients. I think we severely underestimate how exhausting it is to have chronic pain, and how distracting it can be for patients 24/7. And, our memory really relies on intact, well-functioning attention abilities. If we're completely distracted, our memory almost doesn't stand a chance. So there's a lot of literature on chronic pain taking up so much time and energy and cognitive resources that patients will perform slower on tests. Their processing speed will be low, their attention won't be great. It's likely affecting their memory. And I think you have to try to attack it from as many directions as you can. So I refer patients locally. Dr. Sharon Sue, she focuses a lot on non-pharmacological pain coping strategies. So whether that's hypnosis, imagery, distraction, meditation, diaphragmatic breathing, there is research that shows that different non-pharmacological strategies are helpful for different kinds of pain. So I do think it can be helpful for people to see pain specialists. And then, also we have to consider medications can be helpful, but they usually have cognitive side effects. Patients often have, insomnia because of them, or brain fog because of them, or a lot of, irritable bowel syndrome, side effects, all of those things. So I think it's very reasonable to expect that it is significantly affecting their cognitive abilities and their daily functioning or their daily efficiency, and trying to support them in as many areas as you can.
Thanks,
Hopefully
Jeff,
that
for that.
helps a little bit. Yeah.
Question. Thank you for that question. And I imagine that most of us in this community have seen and are caring for people who have chronic pain. It's so common and can be so challenging. And thanks, Ari, for suggesting that sort of team-based approach and not one size fits all. And Julie, I think you may have had your hand up, and then Reza, and then we will shift to the case presentation.
Yes, I enjoyed this so much. I was wondering with the two patient examples, if it was purely lifestyle changes that they made, or were there medication changes? And then a follow-up question on that was, they were both vascular patients, and I know that these lifestyle interventions are good for vascular and Alzheimer's, but I wondered with the frontotemporal dementia, if there's a positive response in that as well, or if it's less so.
Yeah, so good question. So with the patients, one of them was a doctor, and sometimes doctors make the worst patients. So he was prescribed already medication for both his hypertension and his hyperlipidemia, and he was not taking either of them. So I had a pretty long feedback with him, and he started taking the medications that were already prescribed to him. I showed him a lot of research. I sent him articles. I was very aggressive about it. So his was both dietary changes and starting those medications truly for the first time. The second patient was taking the medications, but not regularly. He was often forgetting to take them because of his memory issues. So we came up with a system to use a smart pill box, and his wife got a little more involved to help make sure that he was taking them regularly. So both patients, it was a combination of medications that were already prescribed and changing those lifestyle behaviors pretty significantly. I think with FTD, just to comment briefly, I don't know that there's a ton of research looking at strictly lifestyle changes. That said, there are no negative side effects to eating well, sleeping well, exercising, and becoming more cognitively engaged. It wouldn't obviously cure FTD. It could potentially slow the decline to give you a little more time with your friends and family. So
I guess I was just kind of weighing whether if that's such a hard diagnosis, and I haven't had to give anyone that, but I was just kind of weighing whether they're younger people, they're usually even more eager to do lifestyle changes. So I didn't know if that would be something that would be appropriate. I mean, of course, it's always appropriate, but
it's always appropriate. To be perfectly honest, I tell FTD patients, if this were my family member, we would write up a bucket list. So I would be less concerned about them, eating all their vegetables. And I would say, do you want to go to Italy? Do you want to go to the beach? Like, I heavily emphasize the bucket list conversation with those individuals, just because you don't necessarily even have time to slow the decline. I've had patients pass away 6 months after diagnosis. So I think if it seems to be somewhat slower progressing, for sure, encourage those lifestyle changes while also living within the reality of the disease.
Thank you, Ari. I'll just add one more comment, and then we'll turn to Reza. And this pertains to your question, Julie, about patients with FTD. And there is data for family members who have a genetic variant and who are pre-symptomatic. So often when you have a patient with FTD, not often, sometimes they have a family member as well who has received genetic counseling and who may have the gene. And in this instance, in pre-symptomatic patients who are followed with imaging studies and cognitive testing, they had, as Ari, you said, as you predicted, and you're right, with pre-symptomatic folks, that they had a slower rate of change in their brain.
That's really good to know, because you would not want to advise someone who had a genetic disease if they did something that it could help unless you knew. And so it's good to know that for FTD that can slow and help. Yeah.
Kimmy, do you want to add anything?
Sure, yes. Yeah, it was a cross-sectional study, but definitely very hopeful that even for people who have this gene risk fully penetrant, that lifestyle changes do seem to be helpful. I guess the one caution I sometimes think about in FTD, and sometimes we can have folks that have a very, very long time course. But sometimes there can be a fixation on physical activity, and without the insight of, oh, my feet are hurting, I should stop, that sometimes isn't there. So being able to sort of help somebody with their daily plan, how do I remain a productive member of this household? What are good things I can do for myself and my family every day? I think that sort of advice, incorporating, like making sure that that there are appropriate guidance for how much activity is appropriate.
Yeah, that's a great point. Thank you, Kimmy, and thank you for pointing out there's a cross-sectional study. Reza.
Oh, Reza, I think you're muted.
You're unmuted, but we can't hear you. It looks like you're unmuted.
Oh.
But we're not hearing you. You want to type it in the, is it possible to type it in the chat or?
My question is about tauopathy. How, where is the tauopathy in our differential diagnosis of dementia? Because I think it's very common. I don't know if that's your experience or not, but just isolate tauopathy rather than Alzheimer's disease.
Sorry, can you repeat the beginning of what you said? I think I just couldn't hear you totally.
I said in differential diagnosis of the dementia, where we place tauopathies.
So differential between the different dementias?
How common is that? And because, you know, it's in the textbooks, but I don't see it anywhere in differential diagnosis. And I think many of my patients, I believe, I'm not sure I'm right or not, that, for example, they have dementia, but the course of dementia is not very severe. And patient comes with the MoCA 20, 21, 19, 18. It's about the same over the years. So I thought that's my answer about tauopathy. Mainly, they have tauopathy, not just Alzheimer's disease. So where we put this in our differential diagnosis, and is there any way that you, by neuropsychological test, diagnose tauopathies?
So patients can progress at a glacial pace sometimes, especially with AD. As you know, they're mentioning before, even I've seen a patient with FTD 6 years later. So I think there are some individuals who are, they're clearly doing all the right things. I have other patients who really aren't making any significant life changes, and for whatever reason, their disease is progressing very slowly. I don't know the exact rhyme or reason for that. I know one theory is, a mixed pathology. So somebody could have different pathologies. That's very common. And there's nothing telling us, okay, this is 30% Alzheimer's disease and 70% Lewy body, for example, or 50% this and 50% that. And the different dementias, the more typical cases or your average case, they each sort of have their own progression, but there's nothing to tell us, what's the most influential factor? What is guiding their change over time the most? So for some patients, it might be their vascular factors, which we are fighting against. And so their progression is very slow. They could also have a faster moving dementia, but there are patients that I've seen with a big range of progression. So we talk to them about the typical progression and then tell them though that they could expect differently. And what we can do with cognitive testing is we can test someone once a year or once every 2 years. And that starts to give us a sense of how quickly is change happening over time.
Great. Thank you.
So what they can expect.
Thank you very much. Yeah, thank you. Thank you. Thank you for your question, Reza. And thank you again, Dr. Ariana Tart-Zelvin. Great discussion. And now we're going to shift gears and thank you, Dr. Sylvia Russo from Spokane, for bringing this case presentation or this practice dilemma forward. I'll stop my share. Great.
Thank you for having me. I'll start sharing my slides real quick. I hope you can see the correct version. Yes, probably yes. Okay. So my main questions for this case, and probably there won't be obviously one answer because it's a little complicated, is what is the diagnostic impression that you would have of this patient? And based on that, what treatment would you suggest, if you had them in front of you? So the brief history is that she presents to me at age 83. She's left-handed, and at baseline, she was really social, described by her daughter as quote unquote social butterfly, very vibrant. And starting around 2019, 2020, so probably in her mid to late 70s, she starts becoming more apathetic and withdrawn and starts having behavioral changes where she makes comments in public that are really not appropriate as to people's appearances or people's, clothes. And when her sister passed away, she had very little emotional response, which seemed very atypical for her. At the same time, so at least for what the family can remember, she starts having more memory difficulties. And this is also reported by her primary doctor's notes. Also reading less, more difficulty focusing on tasks. And it's really hard to kind of tease out what started sooner rather than later. Her husband is pretty old himself. He's in his 90s. And her daughter reports that she herself has some memory trouble after a concussion, so she can't remember. But they report that this has been very progressive through the years. In 2022, her primary doctor thought it a good idea that she stop driving. And then around that time, she started having more skin picking behavior, which becomes really severe, really persistent. And the daughter remembers that she had something similar in her 40s, but it was only limited to her shoulder, and it went away, where she was really persistently picking on her shoulder, but no other cognitive or behavioral changes were present when she was 40. She's seen a dermatologist. They've tried pretty much every treatment. They've biopsied the skin, but they couldn't find anything dermatologic going on. Prior history, she had actinic keratosis, some tinea in her feet, some ingrown nails. But other than that, nothing else, and not anything that was persistent when she was reevaluated. Occasionally acting out of her dreams. She sleeps during the day mostly and stays up at night. Occasional hallucinations where she'll see maybe somebody is in the backyard when there isn't, but this is very rare, and it started happening later in the course. And she also was having some wandering at night. This started more in 2022, and she was given Seroquel for this, which seemed to help. Has a long-standing history of presumed essential tremor. It got worse over the years and was seen by our movement disorder specialists who started on Sinemet, which seems to help the tremors. The daughter is very happy with the Sinemet. She doesn't think that it's making the skin picking worse. She started having slower gait, some falls, broke her hip this year, and this caused some progression of her cognition and her behaviors. She lives in an independent living facility. Both of her family members help her with the various activities. Basic activities are preserved, so mostly needs help with instrumental activities of daily living. She has hearing loss, wears hearing aids intermittently despite being encouraged to do it. No other major issues other than a little bit of COPD. She has a long-standing history of constipation. There's no family history of dementia per se, but as I was saying before, The daughter reports memory loss after having a concussion, and there is a history of tremor in the family. Doesn't use any alcohol, limited years of education. And this is her current medication list as it stands. She's on Sinemet and quetiapine. She's on medications for, I think she has atrial fibrillation, I forgot to mention. Both anticoagulant and diltiazem are there, and not much else. And this is what has been tried in the past for the skin picking behavior, which is the main question today regarding treatment. She had Lexapro up until 10 milligrams, no change in her symptoms, and this was maintained for several months. And the same Prozac gradually up titrated to 40 milligrams, no change. When I saw her, I tried fluvoxamine because it was, I found some case reports, again, not a lot of patients, where fluvoxamine, you know, if given low doses and slowly up titrated, could have helped even in the elderly patient with a compulsive disorder like skin picking. But she had dizziness, more confusion, unfortunately, and we tried different formulations of it to help her tolerate it, and unfortunately we had to stop just recently. The dermatologist has given her clobetasol cream, Benadryl cream, hydration, moisturizer, and nothing really helps. Other interventions, so her daughter created or crafted this really neat, you know, sensory blanket with lots of things on it, like pictures of her family and little bumps and knobs that she could, you know, work with to distract her. And unfortunately, she looks at it for 5 seconds and then throws it away and starts picking at her skin. They put like some tube socks on her hands at night and she just pulls them out and doesn't want to wear them. They put gloves on her and she doesn't want them. So really nothing seems to help. And on her physical exam, it's probably the worst case of skin picking that I've seen. And it's really, really diffuse throughout her trunk and chest and back, except in the midline where she can't reach. And in her legs as well, and in her arms. And some of it is kind of like open scratch marks. Others are like more scarred. So various stages of healing. She has Parkinsonism. Her face has got reduced expression. Her tone of voice is softer. She had a little bit of postural tremor. It was less than what it was before. Prior to my exam, the movement disorder doctor said that the left side was more affected. In terms of her cognitive exam, you can see that in 2018, she was seen for the essential tremor, and a neurologist noted that she had reduced graphesthesia on the left, but no stiffness, no rigidity, or anything like that. And then her slums exams seem to have taken a hit between 21 and 22. By the time I see her in August, her MoCA was very low, with kind of a lot of difficulties throughout. And in terms of memory, she had trouble recording the information. And therefore, I believe this also affected the delayed recall. She was not well oriented. She had very poor insight. She couldn't calculate. Both of her fluencies were low. She had some paraphasias where she would call an animal another animal, even with hints. Yes, so for example, I wrote a lion and a rhino were both a wolf. Digit backwards were poor, trails were poor. And just to show you, sorry, she was able to do most of her trails, but then she got distracted at the end. Very perseverative, like she was still copying the picture or the letters on the box, couldn't draw the box. Pretty shaky with her drawing, but her clock was decent, you know. And then her MRI brain was done in 22. And let's see if it plays. They do not make any particular mentions, but when I look at it, I think there is more frontal atrophy than parietal and temporal atrophy. And there is this white matter changes in the right frontal lobe right here. And I can go back and forward later to show you again. So again, more right, but also left frontoinsular atrophy, orbitofrontal atrophy, and then a little bit of mesial temporal atrophy, some parietal atrophy. And again, it's interesting to have that area of white matter change. I couldn't see any microhemorrhages. I didn't show the slides. And no prior MRI than this, no prior CT. She had a DAT scan with the movement disorders doctor, which interestingly enough shows reduced uptake in her right caudate and putamen, also in the left, but clearly more on the right. And then I did a PET scan for her because I couldn't really safely tap her at age 83 with an anticoagulant on board. And so it's kind of a poor man's evaluation, obviously, but the radiologist that is dedicated for us to reading the PET scan said that this was mostly consistent with an Alzheimer's picture. However, I do see quite a bit of frontal hypometabolism. And there is also posterior hypometabolism, but, you know, in comparison, taking into account all the areas, you know, her frontal lobes are pretty dark. The radiologist said, well, if you see posterior cingulate atrophy, chances are with her age, most likely it is Alzheimer's. And I do agree with that. However, when I was reading up on the literature, it seems like longitudinally speaking, there are some studies that do show that the parietal lobe is oftentimes involved in frontotemporal dementia as well, as it progresses. It would be a very atypical presentation, given her age, you know, but the skin picking, some of the apathy, some of the behavioral changes just kind of forced the thought on me to say, is this a very weird form of frontotemporal dementia or FTD phenocopy from that vascular disease? And in fact, there is another paper in a JAMA journal that says that relying just on the temporal parietal hypometabolism to decide if it's Alzheimer's or not can lead to errors. And in fact, it is oftentimes presence in granulin mutations in frontotemporal dementia patients. And truly, it's that frontoinsular network with the anterior cingulate hypometabolism that should raise suspicion for frontotemporal dementia. This is all to say it's a complicated case. She's refractory to medications. And so the open questions remain on the diagnosis. I did notice that area of right frontal vascular disease. They wasn't described as a stroke necessarily, but it could be affecting those caudate structures and those frontal ventral striatal network to cause the skin picking. Is there possibly an AD with vascular pathology? I would find it very odd that it would be an FTD, but you know, it has happened. I have seen it in the past with even older people, even slower progression. And so the question is, how often do you see somebody on both quetiapine and Sinemet together, and what to do with the both of them? My impulse would be to increase the quetiapine, but the risk is, you know, more gait difficulties. And then the other question is, would sertraline be a good try once she's failed 3 other antidepressants? That would be a safer option, obviously. And then finally, they asked me about donepezil, and so did the movement disorders doctor ask about donepezil, which can obviously increase irritability in a person who has mainly frontal and behavioral problems. And there is the problem of the bradycardia because she's on diltiazem. And anything else that, if you've seen any case like this or would recommend anything else, it's really all well received. And also last question, which is probably a side thought, would it be helpful to do genetic testing to see if she has a mutation, which would then be helping us in the diagnosis, and also for her family, her daughter, who's starting to have some memory change. That was the case, and I'm open to any questions or suggestions. Thank you.
Thank you, Sylvia. Really outstanding presentation. Such a synthesis of so much complex information and really challenging the picking behavior. Any questions or clarifying questions for Sylvia from the community? Unmute yourself and ask it or put it in the chat. I saw a hand up actually earlier during the presentation from Esther, I believe. Did you want to unmute yourself and ask the question, or was that? Maybe.
Dr. Russo, I may have missed it, but so she has Parkinsonism, or I think it was mentioned tremor, but then the Cinemed helped. Is it Parkinsonism that she has?
My impression is yes. I did notice some stiffness when I saw her, which the movement disorders doctor hadn't noticed before. She has the features of it. The responsiveness to Cinemed, I don't know what to make of it. The background is, I don't believe her family is very accurate in reporting symptoms. That's my doubt. I cannot be sure of it because I'm not there, and I do believe what they are saying overall. She's just on 2,500 of Cinemed, 1 tablet 3 times a day. They report the tremor is better. We do see there is reduced uptake on that DAT scan. That looks at presynaptic dopamine release. And so if you don't see enough signal, that is also suggestive. It's not specific for Parkinson's. It just tells you that there is some injury in those synaptic dopaminergic endings that reduce the release of dopamine, as I understand it. So it cannot tell you it's Parkinson's or it's another form of Parkinsonism. It just tells you there is damage there. And I think that corresponds a little bit to that area of white matter change. So I think it's a vascular Parkinsonism, which responds less to Cinemed than classic synucleinopathies, but it can still respond. So I wouldn't mark that as for sure it's Parkinson's, but it could be.
Right. I don't think, would you change any of your management if you were to be definitive that this is Parkinson's? I don't think it would make a change in the management of the picking or the behaviors per se, but would you think that Cinemed needs to be adjusted at all?
Yeah, so the Cinemed is a little bit of a double-edged sword because it increases the dopamine action. And many of these compulsive behaviors, as we understand them, from what I understand, are caused by hyperactivation of dopaminergic pathways. And so if we increase the dopamine, yes, we increase or improve the tremor, but can also worsen some of the skin picking if we go higher. And so if she didn't have the skin picking, I would say, well, yes, keep going with the Cinemed. But if she has this, it could make it worse. And I don't know, I mean, it's described as a side effect. I've never seen compulsive skin picking with Cinemed, but it is part of the reasoning there. And conversely, if I increase the antipsychotic, which is an antidopaminergic, would I make her Parkinsonism worse, especially if we think that there is an actual Parkinsonism other than just simply vascular?
And I almost hesitate to say what I would use for skin picking because the kind of antihistamine, like of a low dose doxepine, has been really effective, but it's also like just that risk and benefit in this patient of having those medications. So it's a hard, how severe or how much is it affecting the patient versus that it's just, how severe is it towards the patient, the skin picking?
So she cannot tell us much. She's pretty apathetic, but I cannot imagine that's comfortable. It is horrible. It looks like a plague, basically. It's the best description I can give you. It looks like the plague. It looks like a medieval patient covered in plague sores. So it's horrible, and probably she doesn't mind it, but it must be uncomfortable, and it can potentially cause irritability. And it's then a vicious circle where she picks and it bleeds and it hurts, and then she picks some more. It's really horrendous. And obviously the family is distraught with this. And she doesn't say much of anything. I asked her about it, and she's like, no, I don't hurt. There's nothing. She just shows me her skin, but cannot describe much because she's advanced. But the thing is, it's kind of a quality of life issue, I would imagine.
Thank you. Thank you for that question. And Karen, do you want to unmute yourself, or you had a comment about these blankets and?
Oh, yeah.
Yeah, hi, this is Karen, the care partner representative for Echo Dementia. And just wondering if the family's tried some of these items that you can put on people, blankets or aprons or so forth, that have a whole bunch of different stuff sewn on them and different sensations for their fingers so they can pick.
Yeah, so I know you put in a website. I'm gonna try to share it here. Yes, in fact, she has something that looks very similar to this. I don't know if everybody can see it in the screen. It's just not an apron, but it's a blanket, and her daughter kind of did some sewing, and she put in like a picture of her family and then these little knobs and these little things. She has it, and they tell me that she looks at it for 5 seconds, and then they encourage her to keep it, and then she throws it away and gets mad. And so that I've seen Alzheimer's with skin picking, but usually if you distract them, they catch the distraction and they move on. This is compulsion. This is really compulsion. So I was so discouraged when the daughter said, yep, we tried it, doesn't work. And I'm like, oh, yeah.
And maybe it didn't work a few months ago, and sometimes they change. And there's muffs and there's other.
Yeah, she brings it to every visit just to make sure that she doesn't bleed. And like I had to disinfect her sometimes because she was bleeding in the clinic with the Eliquis, especially.
Right.
It's a complicated thing. So yes, she has it. And I told them, keep having it, keep putting those socks on or those gloves on, whatever we can do to reduce at least some of the scratching. But yeah, the question mark, and I also referred her to a psychiatrist in this because I think it then becomes beyond my scope. I was a little bit worried with the fluvoxamine, and indeed she had a side effect. I was so hoping that she would keep it for a little longer, but they were very scared of the side effects. So I cannot conclude that the fluvoxamine did not work. They just didn't try it for long enough. But if she was dizzy and confused and they really were against it, I mean, I cannot risk another hip fracture.
Yeah, no, rightfully, she didn't tolerate that. Trang, I wonder if you want to comment with your expertise in this very complex, challenging.
Go back to the medications.
Yeah.
This is helpful.
Yeah, Sylvia, that is a hard case, very challenging. So I do agree with you about the typing that can also worsen the disorder, the movement, her tremors. And then if you increase the Cinemet, and that can also increase her skin picking behavior. So I looked into specifically for skin picking, and yes, SSRI is first line. So it looks like she's tried the appropriate one here, Lexapro, Prozac, and you even tried the fluvoxamine. You mentioned sertraline. That's also another option. So one antidepressant is not, if it's not working, it's okay to try another one. Just keep in mind too, a sertraline can also cause ataxia and tremors. So I think sertraline can be tried before increasing quetiapine. My question is, has a patient tried olanzapine before?
I don't believe so, no.
Okay. So then I looked into what are other therapies for skin pricking, and olanzapine is listed, and risperidone. I wouldn't do risperidone just because of her movement orders. And it says that to use olanzapine, antipsychotics can be helpful in patients, especially with delusional patients. So that's something to think about if you want to do one change at a time. So maybe sertraline first, and then backing off quetiapine, and then try olanzapine instead. I was gonna before the Parkinsonian, I was gonna ask because I saw tremor, and I wonder, so what now you mentioned that it's very likely, and then probably just for now, just keep that for now, and because she's still on quetiapine. Prior to this, I thought maybe if it's just essential tremor, has she tried like propranolol before? And how's her blood pressure, and how's her heart rate? Is she hypertensive?
I don't remember whether she tried propranolol in the past, but I believe it was tried like in 2018 when she was having more of it. She's on the Tart-Zelvin for the heart problem, and so there is that combination of calcium channel and beta blocker, which could be problematic. But yeah, potentially speaking, one could try to switch her away from the diltiazem to a beta blocker to help with the tremor more, assuming it will respond, and she hasn't tried it before. But I'll double check if she ever was on a beta blocker. I do believe so. I just didn't put it in the slide, but I'll double check. Thank you.
Right. Because that's a rate control that she can use, a beta blocker for her AFib instead of diltiazem. Unless cardiologist diltiazem is for something else, but it's strict for AFib and a beta blocker to be used. Even though propranolol is not chiroselective, but it can also be used for AFib as well.
Right.
And that can be tried for essential tremor if you have for that. And then your question is donepezil. Was you thinking donepezil because of the FTD?
So I was thinking of donepezil in case this was a mixed form of Alzheimer's, maybe with some synucleinopathy, given her Parkinsonism, constipation, hallucinations. And they were asking me the question to see if it could help with the periods of confusion or hallucination, which, in clear-cut cases of dementia with Lewy bodies, it can be really helpful. But in this case, I'm torn. I don't want to give it because it's usually not a good idea. If somebody has behavioral symptoms, they could get more irritable. But they were asking me the question, and I've been reluctant to it. And now the movement disorders doctor here is asking me the same question. It's like, why aren't you giving it? And I'm like, because it's problematic. So that was my main thing. I am very hesitant to give it to somebody on diltiazem because I've seen really bad bradycardia with it. So yeah, I thought I would add the question. It's less important in the setting of all of her problems, just to see. I would love to have this person go through, a comprehensive brain study with autopsy at the end, because that's how we learn and that's how we know what exactly it is. Just for, learning process, it's really hard to distinguish between these diseases and advanced stages. I've only seen her in 23, so I have limited insight here. But I have to pose the question. And it's not.
It sounds like you have some recommendations to try to hopefully improve her picking. And we're sort of at time, which is why I'm speaking. And then the other thing I'll just add, which I know Sylvia, and we that would be really great information to have, and the likelihood too that she has more than one pathology. It would be really great information, and the probability that she has multiple pathologies is quite high as well. Yeah. So thank you everyone for, if you could stop your share briefly, Sylvia.
Of course, sorry.
No, you're fine. Oh, good.
There you go.
Thank you all. And please, for just reminders regarding your CME credit, if you're UW faculty, staff, or students, then just text this 8574, and otherwise we will track with Samantha, and we'll see you in a couple of weeks on the 22nd for pharmacological treatments for dementia and management of neuropsychiatric symptoms of dementia with Trang. Thank you so much, Trang Lee. Thank you, everyone, and see you in 2 weeks. Thank you, Ari. Thank